So you should be able to see my slides. So thank you again for coming today and for watching the recording. So this discussion that we have today is a really important topic that I know will be quite emotive for many of you. We are going to be discussing mental health crisis management and also some of the potentially and sometimes actually fatal risks that are associated with current approaches to handling crises in some parts of the world. Obviously, we'll be touching on a number of topics that are potentially triggering and uncomfortable for some. So if you need to step out of the recording, that's absolutely fine. And for those watching this later down the line, they may wish to skip parts. So before we start, just some housekeeping. If you're not speaking, then please keep your microphone off so that the recording doesn't pick you up. And please feel free to stay off camera if you're not comfortable with potentially being recorded. As I mentioned, a lot of what we discussed today, it may be triggering, but it also may be divisive. Not everyone will have the same views or experiences. But I ask that everyone please remains respectful, regardless of what you may think about what is discussed today. I think regardless of our views, everyone will be on the same page about wanting what's best for mental health care in the community, whatever you think that may look like. Also, at any point, feel free to raise your hand or comment or send me a message privately if there is a question or comment that you'd like me to feed back. And finally, I would just like to issue a disclaimer at this point on behalf of PLOS. There will be a more detailed textual disclaimer accompanying the recording of this, so you can see that for more details. But in short, I just wanted to point out that any opinions or information shared in the seminar are the views of those sharing them. This does not reflect the opinions of PLOS or any of its journals or affiliated editors. We're making this recording available for educational purposes only, and also to share diverse perspectives. PLOS does not make any representational warranties with respect to the accuracy, applicability, fitness, or completeness of any of the seminar content. And today should not be a substitute for your personal medical advice. So please always seek the advice of your own physician or mental health professional with any questions that you may have regarding a medical or mental health condition. And as detailed in the text that will be alongside this recording, PLOS also disclaims any and all liability for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the seminar content. Okay, on to today. So we're incredibly lucky to be joined by psychiatrist and trailblazer, that's my words, Rupinder Legha. Rupi recently wrote an opinion piece for PLOS Mental Health titled "Reconsidering Calling 911. Is it time to set a new standard for mental health crisis response?" And this forms the basis of the discussion today and will be linked to in the text accompanying the recording, so you can take a closer look at that if you've not already read the piece. Rupi graduated from Harvard Medical School before completing 9 years of postgraduate training in adult psychiatry, global mental health, and child and adolescent psychiatry. And she's worked and lived in Haiti, Peru, and South Korea, as well as the US, in various clinical settings, whilst at the same time developing innovative medical education content pertaining to racism and anti-racism. Rupi launched her private practice in 2021, and she runs a blog called The Full Informed Consent, and this communicates her perspectives of the unstated risks related to child mental health care and child psychiatry. And the aim of this is to help parents to interrogate practices and ensure they're doing what's best for their children. Among her many additional achievements, Rupi is also the founder of the Anti-Racism in Mental Health Fellowship and co-founder of Anti-Racism Healing Collaborative, home of the Anti-Racism in Medicine curriculum series, and she's won a number of prestigious awards for her work. We will run out of time if I try to list everything, I'm afraid, but please do check her site out for more information. And I can just say we're really lucky to have Rupi here today, and also the fact that she's chosen PLOS Mental Health for her work. Also joining us today, we have an academic editor for PLOS Mental Health, Professor Faro. Andre joins us from the Federal University of Sergipe in Brazil, where he leads the Health Psychology Lab. Among many related areas, his current focus is developing resources for basic psychological care in Brazil, aiming to achieve low cost, high precision and brief interventions that are easily accessible to the general population. He's ranked in the top 2% of psychology researchers by the AD Scientific Index and Stanford University in his country, and he's a member of various organisations, including the WHO, the European Health Psychology Society, and the African Academy of Sciences. Please also check out more about him online, as again, we would run over on time if I list all of his impressive achievements. He joins us today and will be contributing to the discussion with Rupi, as he's currently involved in projects that address very similar issues in his country. And it is a priority of PLOS Mental Health to spotlight diverse perspectives as much as possible. So enough from me for now. I'm going to hand over to Rupi, who's going to talk us through her mental health crisis opinion piece and to explain a little bit more about her reasons for writing it. So I'll just stop sharing and I'll let Rupi share her screen as well.
Carly, thank you so much for getting us started. And also thank you for being at the center of this circle. We're all here today because of you. And this paper was given life because of your direction and leadership. And I'm so excited to meet Andre and hear from you and have us all dialoguing together. I'll just pull up my slides now. Are you all able to see my slides? Great. Okay, well, let's jump in. And before we do, a request for us to stay connected on social media. In the weeks since the paper has come out, I've been floored by the dialogue that's emerged in LinkedIn, Twitter, Instagram, and other social media spaces. And after this session ends, it's a great way for us to keep our conversation going. Carly already outlined our disclaimer that the ideas shared today are no substitute or proxy for medical advice. And of course, if people feel that they are having or maybe having a medical emergency, the standard is to call 911 or go to your closest emergency room immediately. Carly already very generously introduced me. I am a dog mom, a good friend, an auntie, a daughter. I'm based in Los Angeles, California, and I'll share with you a couple of other professional touch points of who I am that laid the foundation for this paper. And so this question of why did I write this paper? I think it's also a question of why did I get to write this paper? And some important things to know about me related to my professional purpose is that I fundamentally believe that the inequities gripping mental health in my country and beyond are so directly tied to the training and professionalization and clinical practices that are in place. And there has been inadequate attention given to the need to set new standards of healthcare, of mental health care, in order to address those inequities and create professions that are caring rather than careless. I have a couple of blessed outlets for doing this work. As Carly mentioned, in 2021, I started my own private practice serving multiple states in the United States. Earlier this year, I launched and completed the first go of the Anti-Racism in Mental Health Fellowship with really meaningful success, I might add. And I enjoy writing and teaching and have written and published about a number of topics related to medical training and professionalization, anti-racist clinical practices, and also physician health and well-being, which I feel is another touch point for this paper that we're going to discuss today. these things are important for me to outline because every day I wake up and go to bed unafraid that I might get fired or might be censured or sanctioned by my employer because of what I think, say, and do. Because I operate independently, I get to write papers like this and I feel full freedom to say what I think. So this question of why did I get to write this paper, I want to give a couple of touch points through my professional life related to my experiences learning about policing in relation to mental health care, carcerality, and crisis management. And the first touch point would be medical school and postgraduate training. So adult psychiatry training, global mental health, and also child psychiatry fellowship training. And if I think about the ways in which policing, carcerality, and crisis management showed up, for the purposes of my education and training, I don't think I heard policing or carcerality mentioned once. It was never the topic of any didactic. It did not show up in my supervision, my clinical supervision. And I can think of two stories that bring this together for me. I was thinking about my intern year, which took place 15 years ago. And I can recall being on a night float rotation where you cover the hospital, you're the covering psychiatrist, a couple months out of med school from, say like 6 p.m. until 6 a.m. And I remember being thrown into this practice of being paged to the emergency room to sign orders for somebody being in a physical restraint or having received a chemical restraint. And this is a standard sanctioned practice. And so I would be paged and I would show up and these things, these interventions had already happened and my signature was needed to sign off on it after it had happened. And I was so struck that I had been given all this power, but also all this power had been shifted to someone else and I was signing off on it with really little to no consideration of the harms that I was doing to somebody else. Another example that comes up for me is during child psychiatry fellowship training, covering the emergency room when we were on call. And, here we were in child fellowship, learning a great deal about social and emotional development, adverse childhood events, and the ways in which they shape life trajectories well into adulthood. And simultaneously, I would be in the emergency room trying to provide care to children who were being exposed to so many potentially traumatic things in these busy, chaotic emergency room settings. And what was really notable to me is that there was little to no critique of these practices. This was the standard of excellence and the standard of practice that we were expected to learn, but not question. And so that touch point during that period of time, and then the next touch point being our country, the United States, racial reckoning in 2020. And I'm going to come back to this framework of think, reflect, act that I think is really crucial for thinking of new standards of clinical care. And the training chapter that I just outlined to me kind of captures that think gap of what I was not trained in. And then the reflection issue that came up was being in this moment in 2020. At the time, I was working at a busy county medical center covering an emergency room where people were frequently brought in for acute mental health emergencies. And this was in the aftermath of George Floyd's lynching. This was in the months after Daniel Prude was died after being asphyxiated related to a spit mask being placed over him while in a mental health crisis. And I remember covering a clinic nearby and people being in crisis and needing a crisis level of care according to existing standards. And so often in this moment of 2020, I was getting into the risks and harms of going into the emergency room where I practiced. Those harms related to being further traumatized by what people would see there, the greater risks of being restrained, especially if they were racially minoritized. And as I was sitting with person after person helping to weigh these things, at some point I could no longer be a part of those systems and structures because the risks were really starting to outweigh the benefits. And then the action phase, I have a butterfly here because I think this captures a feeling of freedom and liberation. My decision to try to create an intensive training program that imagines new possibilities for mental health care in this world. And I also want to add that I was blessed to work in Haiti for 2.5 years and Peru for 6 months. And during this time in Haiti in particular, the bureaucratized infrastructure of mental health was, people would say, limited. And so crisis care and management that I was a part of was often happening in communities at home with community health workers. And really the richness of infrastructure was within families and communities. And so I think during this 3-year time when I had no choice but to leverage clinical expertise with these existing resources, it really influenced what I had to say in the paper about how crisis management might look different in other parts of the world. So let's transition into a brief review of this paper related to existing standards for mental health crisis response, my own lived experience, the full informed consent related to crisis management, and we'll come back to this think, reflect, act framework, and hopefully fill some of the gaps that I outlined for my own professional trajectory. So existing approaches to 911, or existing approaches to crisis management, for me to even have on my disclaimer slide something that ostensibly seems at odds with the messaging of the paper, I think it just captures how standard this is. And if you call most mental health providers in this country, their recordings usually say, if you're having an emergency, please hang up and call 911 or go to your closest emergency room. And we know that the police are often the default responders for these emergencies. Some areas do have mobile crisis teams that can show up and be effective. But even when mobile crisis can be an option, and even a worthwhile option, I think that rationale can sometimes obscure what it looks like if people do indeed have to go into an emergency room or inpatient setting, where the practices and what people are exposed to can create another layer of trauma and harm as part of the care. And in my experience, the use of restraints in particular, even though it is upheld as an option of last resort, my experience has been that it is often invoked as an option of convenience. And so I often say to people, there's the trauma of life, and then there's the trauma of mental health care. And the former often cannot be avoided, but the latter should be avoidable. Regarding my own lived experience, this paper is the first time that I've ever spoken publicly about my own mental health history. And I want to just read the excerpt of this paper. And the reason why I want to do it is I want to do this for other healthcare providers who are going through or have gone through similar things. Speaking as somebody who has had medical training and been a doctor, this is just something that we are not able or allowed to do. And I think that in this moment of 2024, we are at a crucial moment where there is a need for all of us to be able to express and articulate what our stories have been as part of reimagining and transforming these systems of care. So what I say in the paper is, over 2 decades ago, I was psychiatrically hospitalized several times over the course of a year while moving in and out of mental health crises. Though I was never forcibly injected or restrained, nor had the police called on me, the threat of it loomed. I cannot imagine how devastated I would have been had it actually happened. Would I have survived? It took me years to move past the trauma, shame, and alienation of the threat alone. The medical and psychiatric profession's entrenched ableism prevented me from speaking openly about my experience, and I was repeatedly discriminated against during my training. For a long time, the stigma felt like a permanent stain, but it quickly faded once I turned pain into power. As part of the oath I took as a doctor, I vowed never to perpetrate these harms against the people I cared for. I will not do to others the things I would not want done to myself, especially during life's most vulnerable moments. As mental health care providers, we should be in professions that allow us to stand tall in our power and share our stories. And the fact that so many of us feel terrified to share them, I cannot think of any grander imperative for us to change the way things are done. The full informed consent related to crisis management. This iceberg image, I think, is a great visual for this, and huge thanks to my social media manager, Luis Chichon, for giving me this idea. And the idea being that the informed consent, which is required from healthcare practitioners, explaining the risks and benefits so people can make informed decisions about their healthcare. What people are often getting is the tip of the iceberg, and the full informed consent speaks to what lies underneath, the harms baked into the mental health care system that we often do not talk about, the fact that policing is not factored into standard recommendations for managing mental health emergencies by many, though not all, guidelines. And if you're interested in learning more about this concept or idea, you can hop onto my website, and I have a number of different posts related to other topics. So closing out with Think, Reflect, Act. As I've kind of moved through an overview of the paper, I'm thinking back to those initial touch points from my career and the ways in which I've tried to fill them with this framework taken from the Anti-Racism and Mental Health Fellowship. And so for healthcare providers, what are the gaps of knowledge that need to be filled related to mental health care's intersection with the carceral state, or the need to understand major racial health inequities and the ways in which standard clinical recommendations can exacerbate them and harm people? And what does it look like to practice giving the full informed consent to people and tell them the whole truth about the risks involved related to trauma baked into mental health care or police involvement? How do we teach providers to write letters of support for people who do have to go to the emergency room, outlining key aspects of recent history and recommendations for responsive, humane care? Something that I have done on a number of occasions. Think, Reflect, Act is not just about healthcare providers. It's very much about all of us who are receiving care in our mental health care systems. And what does it look like to take the stories from the news, like Sonia Massey's or Daniel Prude's or Wiz Rosario's or Ryan Gaynor's, and to bring them into our psychoeducational messages as a form of solidarity and protection for the people we take an oath to not harm? And what does it look like to support people with asking questions of mental health care providers to hold them accountable for honoring their oath? What would it look like if somebody were to ask a psychiatrist, can you tell me what to do during a psychiatric emergency for my loved one? How do you determine whether the benefits of calling 911 and going to the emergency room outweigh the risk of further violence and trauma? These are the kinds of accountability that we need. So my final thoughts as we close out of this simple introduction to this paper is one of inviting questions and imagining new possibilities. And my hope was that the paper would be one small step in that direction to really imagine something more loving and humane for us when we find ourselves in our most vulnerable moments. I also want to note that I think this issue of healthcare safety, healthcare worker safety and well-being, and my own profession, being a physician suicide. In the past couple of weeks, somebody from my circle, an incredibly talented doctor, did die by suicide. And the paper really makes me think a lot about the need for healthcare providers and other professionals and all of us to have spaces that are safe, that feel like paradise, that are loving and humane, whether it's at home or somewhere else, how crucial that is. And I think if we can start to unpack crisis management, I suspect that there could be drastic improvement to other arenas of the mental health care system. I want to close out thanking two people. Akima Aiken-Brown from Real Families for Change played a huge role in this paper, reading and revising drafts with me, talking through it. And then I also want to really give a huge thanks to Carly for making this paper possible. Knowing that there's a journal like PLOS Mental Health that is welcoming lived experience, that is courageous enough to create an outlet to share ideas like this, gives me reason and inspiration to write more papers that help us imagine new possibilities. And so, Carly, thank you so much for everything that you have done for this webinar and for supporting me with writing this paper. Thank you.
Thank you very much, Rupi. Yeah, thanks for sharing your perspective with us today and for openly sharing your experiences, and also your recent tragic news about your colleague. I'm very, very sorry to hear that. It's inspirational to see you starting these conversations, because you're not just dipping your toe in, you're diving straight in. And that, I think, takes a lot of strength and a lot of conviction. And thank you for trusting PLOS Mental Health with publishing your piece. There's so much to talk about, so it will be nice to expand on some of what you've shared with us today, and so we're going to open up to discussion. We do have some pre-submitted questions that I will try my best to cover today, and I've also got some questions as well. But first, I just wanted to hand over to Andre, as I know he's got some important points to raise as well, and to also share his experiences that relate to what Rupi's just shared with us today.
Thank you, Carly. Hi, everyone. It's a great pleasure being here. Congratulations, Rupi, for your presentation. And I will read some notes here as you have done. I wrote down some ideas, and I would like to give some scenario about some background about my opinion. And after that, I will share with you a question for Rupi about the topic, because it's an honor to listen and learn from your experience from your paper. And I think it's a challenging moment, and we have to take this opportunity to change things, to change the way how we deliver mental health care worldwide. And this is I think this is a great problem, a great issue, and your paper is a milestone for me, because when I just read your title, the title captured my attention, and I said, so it's very interesting, and I think she was at the point. And I started to read it, and I commented I think, with Carly and the group, congratulating about the proposal of having a webinar on this topic. So, before doing my question here, I would like just to give a comment about the paper, and so how I was captured by the topic. When I looked up the title, I thought, so that's the point, that's the question, and we have to pay attention on this paper. Since 2020, it's important to highlight this. Since 2020, I think we crossed the turning point in terms of mental health in the worldwide, because one of the most pronounced impacts of the pandemic was on mental health. So it it became very common. We are concerned about our own mental health and the mental health of loved ones, and sometimes not even with loved ones, but with people who lives near us. And we saw that mental health was the one of the biggest crises in that moment. And this was not a question, not only in the perspective of who was suffering from mental health condition, but who lives with a person that's suffering from a mental health condition, since anxiety disorders to psychotic crisis. It became a routine. We discuss, we see news about mental health. And the pandemic itself showed an important gap in our way to deal with mental health questions uh, in Brazil or even other countries. Uh, we realized how important was to be able to recognize mental health suffering and how to deliver proper care. Because not only realize it was enough. We had to be able to refer, to forward that complaint, and share that suffering with other people, and even before to reach mental health care. And the lack of knowledge about mental health conditions, it became very prominent in that moment, because people were talking about depression, were talking about anxiety, were talking about suffering in general, but they didn't know how to handle that situation. And this lack was not only related to personal level. Even the governments didn't know how to handle how many people showing complaints, showing mental health conditions. And from that moment, we started, even here in Sergipe, in our group. This is a small group, but we realized this is a worldwide question. Are we prepared as a person or as a system? Are we skilled to support people who's living a tough moment in their lives? Are we prepared to help each one in their respective role? For example, as a person, as a loved one, as a relative, or even as a common neighbor, or a mental health professional, or a policy officer? Are we prepared to receive mental health complaints and to handle in a healthy way, in a proper way? What do if we consider our own position, what I should do, or mainly what I should avoid to do when I face someone, when I'm dealing with someone in mental health suffering crisis? And I think when we focus on this perspective, this lack of abilities, we also perceive a lack of policies related to this kind of management. And from this perspective, we are able to foresee how big and dangerous is the consequence of not having mental health literacy, of not having mental health uh, skills to deliver and to handle the suffering from other people. And this discussion is not based on only on the perspective of who is suffering from, is on the perspective who lives with, who shares, for example, the same place, and how these people are able people to help other people to deal with crisis moments. And this 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 absence of knowledge shows our society fractures, because we see that the lack of knowledge can be can bring us an interesting thing, interesting terms of very broad consequences, very big consequences. If we ask for mental health, we can be in a dangerous place, in a dangerous position. This should not make any sense, but it does. So asking for mental health can be dangerous, might be dangerous. So we have to do something in relation to this issue, because it's a dissonant reality. Who is needing help can be in dangers, can be in a harmful situation for asking for help. So, my opinion on the paper from Rupi, I would like to give a suggestion to Rupi write a new one, but not as a question, as a target. Actually, it's not is it necessary to have a new standard? It's not a question. It's the point. It's the end point. We must have a new standard, and this standard is not only based on the view of who's suffering, but to provide the proper care. And everyone should be able to understand, at least at the minimum level, how to handle mental health adversities. Because this kind of knowledge, this kind of expertise, even in a psychological basic care level, it can be it can save lives, actually. because you will be able to protect who need protection and to understand how to help these people. So for me, I think it's not a question to have a new standard. It's the point. We must have a new standard. And the pandemic period was, I think, it's a turning point in our history because mental health became much more discussed, much more common sense. Everyone discussed about mental health, and this is maybe the best moment to change how we handle mental health adversities, not from the victim's perspective, but also from the society at all. Each one in his position, in her position, understand their role and to develop basic skills to deal with these questions. So I would like again to congratulate Rupi because she gave her attention on this topic, and from the title to the end of the paper, I learned a lot, and I thought this is a worldwide challenge. This is a big challenge. Asking for mental help should not be dangerous. Should not be danger. This is this is it's interesting because if we think on this expression, ask for help can be dangerous, doesn't make sense. So it's we have to change the situation. And my question is, what do you think, Ruth, about unscaled care? Because I think a stepped care is a way to handle mental health crisis. For example, in terms of suicidal behavior in Brazil. In Brazil, we know we have an important rate of suicidal behaviors in Brazil, but we just collect data. We only collect data on severe attempts against one's life and deaths by suicide. For example, we are missing a lot of information about suicidal ideation, suicidal attempts, that and these points are less urgent levels that we could handle the situation without reach the extreme outcome. For example, ask for urgent care because this urgent care might be more dangerous than we handle, for example, suicidal ideation. And we don't have this data. This is for example, there's a gap in Brazil. And what do you think about stepped care could be a way to improve this kind of communication? Or I would like to use the topic that we are we are using here in my lab, improve mental health literacy in general through a stepped care model.
Andrea, thank you so much for sharing your expertise and perspective. And I was writing down notes of all of the really pithy things that you were saying that are worth thinking about. And I love what you're saying about a stepped conceptualization and thinking about people before they reach the crisis point. And what it got me thinking about, as you were saying, this is not just about people receiving care, this is about all of us, this is about everyone worldwide. You know, in the United States, people are talking about a pediatric mental health crisis. There's so many labels to capture what you're describing post-COVID, so we can call it so many things, but there's such urgency. And something that immediately came to mind for me is the need for us as an entirety to think about suicide risk everywhere. So we don't often think about suicide risk related to medical training and professionalization, or we don't talk about suicide risk in relation to workplace toxicity or suicide risk in relation to bullying. And so there's so many ways in which this risk exists, but in our workplaces, when we are with our teams and colleagues, we are not thinking about suicide when a boss is abusing someone, or we are not thinking about suicide when, you know, neighbors are engaging in a way that is toxic and damaging. And so I think thinking about it from a stepped point of view means suicide risk and mental health crisis management are as you're saying that it is applied to any and all things that are happening in our communities and societies.
Thank you. Andre, did you have, I think you had another question for Rupi as well.
Yeah, thank you, Rupi, for your answer. I would like to share with you another idea. For example, we have in Brazil, we have it's a low and middle income country. It's not easy to delivery to hear people and deliver because we are in a huge country. It's not as easy it should be to contact people and deliver care. And we have a lot of alternatives that could be applied. For example, telephonic mental health support. We could improve this instrument to deliver care to listen people and other online ways to improve how we listen people and deliver care. This is the main point. And what are your suggestions for how we could apply this idea to have a like a ground zero mental care? For example, if you need the most basic guidance in mental health, how we could apply this in reality, for example, where in some places where we have very limited resources in terms of delivering care.
Yeah, well, I'd love to give one touch point of my own experience, and then I suspect other people in our circle today have even better thoughts to share. But you know, one thing that immediately comes to mind for me related to my own experience working in Haiti relates to community health workers, and I think we can call it community health workers, we can call it peers, we can call it family members. It can look like so many things. But to this idea that you're talking about, Andre, of what does it look like for all of us to have knowledge and awareness of crisis management, I think about people in the community who are the experts on what's happening in their local worlds. And in my own experience, the community health workers that I was fortunate to work with in Haiti were really the most expert, most skilled, and most valuable asset for the mental health care system that was being built. And so I really think about ways to bring things to the people. And, you know, I know people get excited about apps and technology and their ways, you know, that these things can be leveraged responsibly, but that's what immediately comes to mind. And I wonder what other people think as well.
Thank you, Rupi.
I guess my question, I guess, related to, and we did have another question that was pre-submitted about the use of telephonic mental health in crisis intervention. Obviously, there's pros and cons to that, right? Because the pros, accessibility, and it's easier to, you know, for apps and telephonic mental health care to reach communities. And, you know, also, you know, some people who may struggle with reaching out because of fear of stigma, and they can do it maybe more anonymously by texting. And I think, you know, it's got such value. But then you lose that human side to some extent. And, you know, some people, things might be missed, or, you know, you may not pick up on nuances in the way someone's expressing something. Say you're using a text service, the text helpline. You may not, you know, you get a lot from body language, right? As a therapist, psychiatrist, you get a lot from inflections. You're not going to get that from the text. So do you think there would also be a risk with relying on too heavily on technology for mental health crisis management?
Yep, I think. Sorry, Rupi,
No,
please.
go ahead, Andre, go ahead.
No, I think it is a very interesting point, Carly, because, for example, the way to listen, it will change a lot when we are texting or when we are claiming for help. It's interesting because maybe sometimes i- in a perspective of a scaled care, stepped care, sorry, in a stepped care, for example, it's something like we have to have a very basic way to deliver, but this should be step to find another person, another way to deliver that complaint. And considering, for example, the level of urgency, we should be able to give for example, if it will be mediated by technology or not, that kind of complaint should be listened in person, face to face, because that kind of complaint is not captured at all overall in through messages to call, for example. It's very interesting this point because we have to think in a in a big way, and to see in each level of urgency what we should deliver as the best way to listen that people.
Yeah, absolutely. Eliana, I think you've got a question.
Thank you, Carly. I just want to first just say, Dr. Legha, thank you. Thank you for this article. Oh my goodness, this is exactly what we need right now. And your courage in speaking so directly about the risks in the current system, as well as your own experience, are earth-shatteringly powerful. So thank you for that. I wonder if you could speak a little bit about, excuse me, when you mentioned how workplace abuse or how tensions with neighbors can escalate discomfort to a point of crisis. I wonder if you could share a little bit about the idea, your opinion about the idea that we refer to mental injuries rather than mental illness as a way to destigmatize what our experiences are, which might then translate out to a system that is actually dealing with the structural issues that are leading to those mental injuries rather than pathologizing us for feeling injured.
Liana, I feel like you laid it out so beautifully with the question and explanation. I'm so grateful for your expertise with bringing this in. But no, I think that's exactly right. Shifting from what's wrong with you to what's happening to you and what's being done to you, and capturing the injury component. I mean, I think the glasses that I have on, the vantage point that I have on is, watching and engaging in human activities and the human process, and really thinking about risk of harm and benefit of harm, and protection and vulnerability, and seeing that everywhere. And I think to Andre's point, recognizing that this is something affecting us all, this is our thing. And so I think you laid it out beautifully with your statement, how crucial that is. And I think about the stories of people who have died by suicide, who've been in the news as a result of workplace bullying. And when I see those stories, for me, and again, this is my own opinion, it really feels like somebody murdered them to me. It really feels like they were killed. And we can talk about that in relation to suicide resulting, 2 or 3 steps away from workplace toxicity. We can talk about that with Black maternal mortality in this country, whether it's 1 step away, 2 or 3. Every step is bringing someone closer to death, and it's murder. And so, yes to everything that you're saying.
Yeah, I think I'm glad you've said that so explicitly. I think that there's a lot of, I mean, I can only speak for the UK. There's a lot of companies, workplaces that are trying hard, or at the very least are trying to tick boxes, but there's some that are absolutely terrible. Where I used to work, not where I work now, or where I worked before that, but many years ago, reaching out for mental health support, I've got it in writing still, was told, no, we don't offer anything because the onus is fully on you to look after yourself. And whilst the onus, of course, is on us to look after ourselves and be empowered, you know, we spend so much of our time at work that you cannot say that work has zero responsibility for your well-being. It's ridiculous. I'm very conscious of time. I always feel guilty when I'm conscious of time, and I knew I'd feel especially guilty with this topic. So I'd like to just get some more questions in that relate more closely to the opinion piece and some of the submitted ones. So one of them I would like to ask is, say we have a family that has someone in the household with a mental health condition, and they're going through a mental health crisis, and it's very clear that they need urgent support because they're fear for their safety, the person's safety. What would your advice be if they felt really cautious about calling in emergency services for whatever reason? What would your advice be to that family?
Yeah, so I think this question, it comes up and it's an important one. And, you know, I think about how new possibilities, and with new possibilities, new considerations, and some might even say new risks. So when somebody is in crisis, and in fact, if they are perceived as being threatening or dangerous to family members, you know, I think where maybe we get pushed up against the wall and our imagination shrinks is feeling like there's no option but to call the police or to invoke a mental health crisis response that involves restraint or physical containment. I think the piece that gets lost is when people know or fear that that's the crisis response, they become more terrified and are prone to move into a defensive mode. And so, you know, what I've seen, I mean, I can even think of incidents where I've watched neighbors and even a mobile crisis team has shown up, and I see people circling the person, and even if they're not threatening, I don't know, if somebody shows up on my porch and there's a circle of people standing around me, I feel terrified. I feel very differently when someone has made some food and is offering me food or bringing their dog over to say hi to me. And I don't mean to be flippant with this, but there's real traumatic activation related to crisis management that freaks people out. And so what happens when that physiological loop gets broken? What happens when crisis management feels like paradise for us, when really amazing things come from having that retreat, from having that space, and from having those people? And so I think that's one piece that's really important to think of, that that scenario just begets the risk of violence even more so, because the existing options are so activating and terrifying for people.
Yeah, that's a very interesting point. If the families or the individual know that by reaching out, there's going to be something that helps them, or even if it doesn't necessarily feel like it's helping, it's not going to make things worse and more threatening, then, you know, the anxiety levels will immediately decrease and they'll calm down, and that'll kind of maybe de-escalate the situation a bit. Some of the other things that you've written, the way you practice is, and obviously I may have misinterpreted, but you do take on a lot of responsibility for the people that you work with, and you know, you are more open to being contacted in a crisis and this kind of thing, which I think is very admirable. As we've spoken about before, I think a concern that there would be a lot of mental health professionals that would love to be able to provide that kind of support, but they would worry about their own mental health or burnout. What kind of advice would you give to a mental health professional who perhaps would like to work in that way, but is worried about that burnout and, you know, keeping themselves performing at their best?
Yeah, great question. And so, we are imagining and envisioning this world that Andre started to lay out for us, of us all being a part of this and it being our shared movement. And so, how do we hold on to this large vision of this is the standard that we're all engaged with, and we have new practices and new systems and new realities that completely uphold it and cater to it? And then how do we hold on to that perspective and recognize that we are in the early stages where each thing is a step? So, for me, one big step was my own experience and process of developing these practices in my own life. And when I was at that step, it was two things. On the one hand, I was floored by how liberating and joyful and effective this was. So one practical thing was that these steps, which are emotionally and even physically demanding, they're so impactful that they probably have lightened my workload in the end, because they are so much more effective. And so how do you think about the risk and benefit of doing the old things that don't work and make things worse and make me feel like I've failed as a provider? And then how do I unlock the possibility of trying something new and different that makes more sense, that feels more humane, and then seeing what's on the other side of it when, say, people might not even need the level of care that they required before? And so I think thinking about that, and then the next step for me beyond that was to try to codify some of these practices and bring other people into them. And I think the fellowship speaks to that. And I can think of that small community that formed earlier this year, and what did it look like when there was more than one of us in the room sharing ideas and talking about things. And the smoke screen of what we had been trained to do started to clear, and then the joy and liberation on the other side of coming together to engage these practices was there. And we're still in the early stages of these small steps, holding on to that broader vision. But imagine what happens when all of us are together doing it together and innovating new approaches so that it becomes more sustainable and less demanding and onerous for one single person.
Thank you. We've probably got time for one or two more questions. Does anyone have a question? I don't want to hog all the questions. Otherwise, I do have more. But the other one I wanted to ask is, it's a bit of a vague one, but kind of where would you draw the line in terms of responsibility between the mental health professional and law enforcement? So I'm thinking of a recent, quite high profile case that we had in the UK recently about someone who ended up murdering 3 people. They had a mental health condition, and their mental health providers were concerned a while back that they were capable of killing someone, but they weren't able to get the support that they needed. So in a case like that, how much responsibility do or should mental health professionals have in a case like that, and how much should be law enforcement in terms of navigating that and making sure everyone is handling those situations correctly?
Yeah, so I might say something that's not satisfying for that, but as I was listening to you pose that important and frequently asked question, what came to mind for me was this a mental health issue? And why is this a mental health issue? And I think this goes back to some of those touch points that I was sharing from my own professional trajectory, and this idea of policing and carcerality and crisis management. And why is it that these things are so woven together that this is our question that naturally arises? So I think my response to that is, why is this a question of mental health? How are we thinking about mental health in relation to carcerality? I think that this question that comes up so often among professionals and the public, I think we have to think a little bit about why that's the question being asked, and really think more about policing and carcerality in relation to mental health.
That's a really interesting perspective. Definitely, it's kind of flipping the perspective there. So we've got time for one more question, if anyone wants to take it. Eliana?
I was so moved when you were talking about the community health workers as being this unique resource for help. And I think about, if you could just talk a little bit more about that, please. Like, what were they bringing to these interactions that was so?
Oh gosh, yeah. And I want to preface by saying that I was a foreigner, an intruder, a moon blonde in Haiti, and every time I landed in Port-au-Prince off an airplane, I would question why I was allowed into the country. And so I really want to acknowledge the violation of my even being there, and then the fact that I was able to be there. And so I mean, I can just think of story after story after story. And do I give his name? There was a gentleman, we had the same birthday, and I still sometimes get text messages wishing one another happy birthday. And a brilliant soul, who also happened to not be able to read or write. And we would do epilepsy management. And there's so much interface between epilepsy and psychosis, and really very real risks related to epilepsy in terms of falling into fires, drowning in rivers, entire families having multiple children die as a result. And we know epilepsy management is so accessible and feasible. It just requires proper diagnosis and treatment. And I can think of times when we would be on the phone together, with my lackluster Creole, and I would get a picture of epilepsy, and then it was someone that I could not see. We're talking about medications that in the United States have labs that are drawn before they're even started. And I can think of the times working with this person, and I mean, honestly, he was the doctor in the interaction. It really wasn't me. And his wife would help him dole out the medication and keep track of it so that it was never, especially for the kids, so that it wasn't mismanaged. And so, I can think about what it was like for me to shift into this gray area in relation to the very Western training that I had been given as an adult psychiatry resident, and really a reconfiguration of risk and benefit. Because had I applied a risk benefit analysis related to one that I was trained in, I would do nothing. And yet reconfiguring the potent benefit from his presence, expertise, and grace, and then the ways in which I was an accessory to his care. I think he managed to reach hundreds of people with epilepsy management. And I'm saying, interacting with families where almost every child in the family had passed away due to not being diagnosed or getting proper care. So I think about that, and then I can think about recent examples working with families where talking to moms in particular, and saying, you are the doctor here and I'm here to help, but you have essentially provided around the clock care that would have happened in an emergency room, and you've done it at home. So who is the real doctor in this equation?
Thank you. I'm really sorry to end it now because we're at time. I would say I wish this conversation could continue, but I'm sure it will anyway. I don't think this is the end of this conversation. I think there's various things that will be coming up because it's definitely needed. But thank you again, Rupi, for joining us today and for sharing your perspectives, and just really, I think, educating us all, actually, and really opening our eyes to things, and being so brave and so explicit in your messaging. It's really important. There's no grey area with a topic like this. And I also wanted to thank Andre as well for coming along and sharing some of his perspectives from his work, and everyone that's joined us today. And if you are watching the recording and you have any questions, then feel free to reach out to me and I can channel them to Rupi if that's okay with you, Rupi. But otherwise, thank you so much. And hopefully we will expand this in another way soon.